Hello everybody, welcome to iCubed. This is episode 23 already. Oh my goodness. It is now November in Arizona and it's just gorgeous outside. I know you guys are listening to this in January where it might be below zero where you are, but it's just beautiful in Arizona. I want to welcome you to this month's iCubed. I have a brand new guest I'm so excited about. He's from my Residency, Maricopa Medical Center, Cristian Patterson. Ta-da! Can you please introduce yourself?
Yes, like she said, I'm Cristian Patterson. I am brand new. I just finished residency in June and started in July. It was a rapid turnover. And been having a lot of fun here at Banner Baywood.
Great. Where did you go to medical school?
Did medical school at Midwestern University here in Glendale.
Oh, wow.
So I'm kind of like Arizona bred and fed. I've been here my whole life for the most part.
That's wonderful. Well, you've been a great addition, Cristian, I have to say, to our group here. And I've explained to you with iCubed that we'll initially just talk about a case, and you know these cases are all what we see in our ER. You've been here 3 months. You know what it's like here.
Lots of sick patients.
That's exactly right. So we have a lot of critical patients, and so we're going to just plunge into this case. So this is a night shift, end of my night shift, 6 o'clock in the morning. The triage tech comes over and brings you this EKG. He's having chest pain. What do you think?
Oh no, another one.
Right.
And it's probably the 300th EKG I've looked at today.
Right, exactly. Yeah.
So looking at it, I would say, it looks like it's narrow complex. It looks a little bit fast. If I was just glancing at it and saying whether we needed to get this patient back immediately, let's say, he's a little tachycardic, but I see P waves everywhere.
Right.
Narrow complex.
Yeah.
He does have some T wave inversions in the lateral leads. Yeah. So I would definitely want to check that against an old EKG before I just handed it back to him and told him to go wait in the waiting room.
That's right. You are correct. So, of course, I immediately pull up the old EKG. And what do you think? Just take a look at that.
So, yeah, looking at that, it's similar, but those T-wave inversions are definitely new in the lateral leads, so I'd be worried about acute ischemia.
Right, I thought so too. I looked at that and I went, okay, bring the guy back. Okay, he's having chest pain and he's having new changes. You can't just let him sit in the waiting room, just bring him back. So about 6:30 now, it's the end of my shift, my night shift. So
another thing that's tough with some of these patients, though, is like you'll get a triage EKG and you can't see what they look like. Are they diaphoretic?
Right.
Do they have nausea and vomiting?
Right.
Do they look good? Or is it just like someone looks fine and just says, I've got a little bit of twinge in my chest?
Right. So one of the challenges is, of course, how accurate the tech is describing the patient. They may say the patient looks fine, but when you see him, he's not so fine, right? Or the patient may have a different complaint than what the tech is conveying to you. So we have to take what they say sort of with a grain of salt in a way. So I asked the tech to bring the patient back. We walk in the room together with the nurse and all. And so you find out that this is a pretty fit-looking 52-year-old male, and he has a history of diabetes and hypertension, right? He came in complaining of severe anterior chest pain and shortness of breath, and it started last night. He's never had a history of this. He says that he just flew back from Chicago in the past few weeks. He hasn't drank alcohol all week. He doesn't smoke at all, and he doesn't have any asthma or COPD, no pulmonary history. So then he describes his pain as tight, there's a pressure, it's making it hard for him to breathe. And then it's diffuse and it's located anteriorly. What do you think?
So you got to consider ACS. You got to consider heart attack. Even the guy looks pretty good, and he's not a tobacco user. But especially somebody that's diabetic as well. Yeah, I would be considering ACS.
Sure.
Flight from Chicago, not exactly an international flight. No. Maybe back burner, maybe think pulmonary embolism, but he's not that fast. And if he's not hypoxic, it's something to consider, but I don't know that I'd be ordering the CTA right off. Right. I'd probably be looking more for ACS type picture.
Exactly. So, you get a minute to talk to him. His past history is very minimal: hypertension, diabetes. He's on just insulin. His surgical history, he's had a vasectomy. Social history, he said already, he doesn't smoke, never smokes, and he hasn't drank all week long. By looking at him, you see that he's in distress. He is breathing hard, okay? The vital signs are blood pressure 149/80. His heart rate is a little on the fast side, 122. His respirations are 26, so a little on the high side. His sats are 100% on room air. His temp is afebrile orally. He's actually a fit-looking 52-year-old guy. He's sitting up and he's breathing his labor. Okay, he's speaking short sentences. He looks distressed.
Yeah, at this point, I mean, with that heart rate, with that respiratory rate, now I'm thinking pulmonary embolism may be a little higher up there. If I had an ultrasound, I would love to put it on, just take a quick look.
That's great.
We've got the dinosaur ultrasounds here. I was spoiled in my residency program. We had brand new ultrasounds.
Oh, that's great.
But
so, Chris, what would you see on the bedside ultrasound if you're trying to kind of looking at someone with undifferentiated chest pain?
So, I mean, I kind of dumb it down. I'm not an echo tech. I'm not great, but you can look for just some general wall motion abnormalities. And if you've done enough of them, sometimes you can see those. And then you look for like a D sign if you're worried about a pulmonary embolism, and D sign is just, dilation of the right ventricle compared to the left. Like if it looks big, that would push me a little bit more down the possible pulmonary embolism route. Right.
So as we go on with this interview, he starts to vomit. He actually only vomits once, but he's been hyperventilating. He's been labored, probably swallowing a lot of air, right? Or was the vomiting due to his actual chest pain? Who knows exactly? Right? He doesn't drink, supposedly, or hasn't drank all week. So this is your 5 minutes with your patient. What are you thinking now? What would you do? Any more history you want to know about him?
I mean, for this one, again, so now he's vomiting. Right. Now that's making me lean maybe back towards ACS. So but then, I'd initially, I'd send off blood work. For my differential, I'd be concerned about maybe even a possible dissection. It doesn't sound like it because he's not describing this tearing pain.
Right.
He does have the history of hypertension, though, that puts him at higher risk. No history of tobacco use, but, I'd consider the big ones. So ACS, dissection, pulmonary embolism. I'd definitely get a chest x-ray. Sometimes you can see whether they've got the widened mediastinum. And then, for this guy, I would definitely be getting a trope on. It sounds like it's been several hours, so I'd expect that to come back positive.
Right, exactly.
And then, I would get my, my basic blood work, my troponin sent off. Consider a BMP, and then again, I'd be on the fence about maybe pulling the trigger with the CTA to look for a pulmonary embolism.
So for me, my major differentials on him, when I looked at this guy who was in a lot of distress, actually, in my opinion, was number one, ACS. He was having a coronary syndrome. We saw the triage EKG, new ST inversions or T-wave inversions, right? That's the first thing that worried me, and I wanted him to come back right away so I can see him face to face. Of course, I thought PE because he was talking about flying to and from Chicago within the past couple of weeks. I know Chicago's only probably 2 or 3 hours away, or 3 hours away, but it's nonetheless, you can't rule that out just based on that. Pancreatitis, I thought, because he vomited, right? And then dissection, like you said, it's certainly possible. He's a history of hypertension. He's a male. He's having a lot of chest pain, although he's not describing it as a classic dissection type of pain. But you have to keep that at the top of your differential, right? So those are the 4 main differentials I thought of as soon as I saw the guy. But I am pretty aggressive in terms of, if I suspect this is ACS, I will always start them on either nitro drip, or nitro sublingual or a paste, and then put him on heparin. So in him, what I did was essentially go down the road of PE and chest pain workup, and then starting him on treatment for ACS, right? So I order the studies, like you had talked about, and I ordered some studies, and one of which was a portable chest x-ray, which is shown here. Anything?
Doesn't look particularly wide to me, but again, I would wait for, I'd look at the radiologist read, and then I don't see any, calcifications in the aorta, but granted, this is just a chest x-ray, so.
Yeah, me neither. I saw this at the bedside, actually, and it didn't really strike me as anything to worry about. So we get him back. Remember, in the timeline, he's back in the room at about 7:30, and I've all these things started. My treatment has started. I've got my orders, verbal orders given. They've drawn the blood. At about 7:30, I go back to check on the guy, and in the meantime, of course, I'm getting nurse updates, right? So get back there. He's still looking like he's in pain. He now is on heparin. He's on the nitro. We're dialing up the nitro to help him with his chest pain. No change of his chest pain. He's still short of breath. He's still looking distressed. And the chest CT was done. I called over the radiology, had him do it right away without the labs, actually, because he's young and pretty healthy, except for the diabetes. But the results are still pending. So 20 minutes later or so, I go back and check on the guy. You know, the nurse was saying he's really anxious, hyperventilating. So I said, okay, let's just give him a little Ativan. So it's made him drowsy. So he's visibly calmer and drowsier. He says his pain is a little bit less. He's less short of breath. Now he smells ketone.
Diabetes.
I'm glad you reacted that way. So now I'm standing next to him. He smells ketotic.
And he's breathing fast because he's got DK.
So far, no chemistries are back, right? I'm down this PE chest ACS route, and then I'm waiting for studies, and then I smell the guy. I'm like, OMG. He said he just started a ketogenic diet this week. I don't know what that means, but so I'm like, I leave the room. I'm like, get the AccuCheck. Get the AccuCheck.
487. Yeah, I think you did this to me on purpose.
Oh, the patient did this to me. Oh my gosh. I'm like, I know that people say that the ability to smell ketones on patients is really sort of, I guess, individual. Some people can't, and maybe it's genetically based. But I always, in my whole career, I've always been able to smell ketosis. And I'm going to blame the fact that he vomited during my first interview with him, that I couldn't smell anything, you know. But here I'm like, this is 90 minutes or so into his ED stay, and finally I'm like, oh my gosh, I didn't even think about DK. The guy's got DKA, right? So we make this left turn. Get the blood gas. So here's the blood gas.
Oh man. Well, he's respiratory compensated.
I know. So now you can see him right in your head. He's just hyperventilating because he's compensating for his metabolic acidosis. You see, I mean, this is remarkable. His bicarb is 2. His base excess is less than 30 or minus 30. And his PCO2 is 9. You know, his pH is 6.90. He's just hyperventilating up the wazoo, or Kussmauling up the wazoo to compensate. Now, you are a brand new attending. Have you ever seen this type of shorthand before?
So believe it or not, the first hospital that I was in as a medical student had their results came back on electronically, but the charting was still paper. So we had to write paper charts as a medical student.
Oh my gosh.
And so I did write
you had
this
to do all
many
that.
times.
So that's fine. That's good to know. So it's pretty remarkable. You can see that the bicarb is 5. And his potassium is 5, right? So the glucose is 486. Sodium is 131, which you would expect. Actually, I'm surprised that it's as high as it is with the glucose of 400, almost 500. His troponin came back 25, and his CT chest finally does come back. It's negative for PE. You can see his hemoglobin hematocrit looks very hemoconcentrated, right? He's got a 19,000 white count as well.
And I think we should tell our listeners troponin of 25. We're using the high sensitivity troponin here nowadays. So a troponin of 25, although might cause tachycardia in you, it's actually not very high here. It would probably be the equivalent of what, like
about a 0.02.
0.02. Yeah. So it's pretty low.
Very, very low. So we admit the patient, of course, for DKA, with DKA to the hospital, it's the ICU. But so I'm talking to the hospitalist. She sees the patient. She comes out slightly panicked, and she's like, "He's really in a lot of distress. We need to intubate him." So we have a little discussion about that, and in my way, I try to convince her that no, you don't want to do that. You don't want to intubate this patient with DKA with severe metabolic acidosis who's compensating with the hyperventilation and Kussmaul breathing. So she believed me, I think. But anyway, the patient did go off to the ICU. Any thoughts about the case so far?
I fell for it.
You sure did. So did I, and we'll talk about this in our learning focus. So, as you know, my my iCubed has this case presentation, and then I really do try to focus into 2 points where we can learn something from this particular patient scenario. And these are, hopefully are not just regular didactic things, but something unique about this particular case that we can all learn. Even someone as seasoned as I am, which is 26 years in ER doc, can learn, and then someone who's just freshly out of residency like yourself can also learn. So, focus number 1 is severe DKA. In my research, I found a lot of information, as you probably know. There's just a ton of information, a lot of teaching about DKA, but this in particular was a very useful article, and it really spoke specifically to this case, because when that hospitalist questioned me, I had a very ready response, but I also had vague memory of the reasoning for why I said what I said. So I looked into that, and this article in EM Docs, titled Airway Subtleties in Critically Ill Patients, it was published in 2014, and the author talks about a few different scenarios, including the DKA patient in metabolic acidosis, but the author also talks about aspirin overdoses. You don't want to intubate those. I don't want to belabor the DKA subject, but let's go through a few things that I think that'd be helpful for us to think about these patients. So DKA patients take up more than 500,000 hospital days per year, at the cost of $2.4 billion US dollars per year. These patients, like my patient, can look really awful. They're very, very ill. They can be very, very ill. So the DKA patient with severe metabolic acidosis could be hypotensive. They can have respiratory failure. They may have underlying sepsis that you have not discovered yet upon presentation. Their electrolytes are usually really off, right, like ours. And then they're in severe metabolic acidosis. These patients are usually breathing at maximum for the reason of respiratory compensation. They're so acidotic that they are breathing like a bandit, just trying to breathe out the CO2 and trying to bring the pH up. Intubation of these patients with severe metabolic acidosis using standard approach can actually kill the patient. And that was my point to the hospitalist. The standard approach can result in a period of apnea, and apnea can kill because the patient needs that respiratory compensation. And when you intubate the guy or the woman, the patient, you took it away because you're paralyzed them. You've taken away that you've taken away their respiratory compensation.
And it's hard to keep up with that using the ventilator.
Oh, totally.
It's because they're breathing so fast and so deep that it's really hard to replicate that with a
machine. Yeah. So then I looked, and MCRIT, Scott Weingart is great, a critical care ER educator guru. He has a podcast from 2009 that's a very short podcast. I would recommend people listen to this. It's about 8 or 9 minutes, and it's just very sort of down and dirty main points about what do you do when you do have to intubate this critically ill patient with a severe metabolic acidosis. And so you want to pre-oxygenate the patient before you intubate them. You do not want to use sucks if you suspect or you have documented hyperkalemia, right? Because of the risk of hyperkalemia from succinylcholine. This is really important. Avoid any period of apnea by initiating slow ventilatory breaths, about 12 breaths a minute or so, as soon as you give the paralytic. So then when you're talking about the pre-oxygenation, you use a BiPAP mask, you attach it to a regular ventilator, not a BiPAP machine or non-invasive ventilation machine, and set your ventilator on the SIMV mode. This is really the most important point with the pre-oxygenation, which is to set the respiration rate to 0, and this allows the patient, therefore this allows the patient to breathe on their own when you've got them on the BiPAP. Make sure the patient's on 100% O2. You set the tidal volume at 550 cc's. You turn the flow rate down to 30 liters per minute as opposed to 60 liters per minute, which is the usual ventilator setting. You put your pressure support at 5 to 10 and PEEP at 5. Yeah.
And then one other thing with this is, with BiPAP, they always teach you if they're altered, you can't do BiPAP.
Exactly.
But this is not, it's okay in this situation because you're not doing it permanently. You're not like walking away from them. You're not putting them on the floor with BiPAP.
Right.
You're preparing them to intubate.
Right. So you're watching. Yep.
So you're keeping an eye on them. It's okay to use BiPAP in this situation. I'm studying for boards right now, and I just know that my board test is Monday, and I know that I've hit this before. So.
Oh, the perfect time to review for you then. So then after you do the pre-oxygenation process, you go ahead and give the paralytic and you wait for the full paralysis to kick in. But during that time, you have to make sure you have apply the jaw thrust to open up the posterior pharynx. The most experienced intubator should be the one intubating the patient because there's a much higher chance for first pass success, right? You have to have a end-tidal CO2 monitor attached to the vent. Make sure that you keep that reading as low, at least as low as it was pre-intubation. All right. So if they were like at 5 or 6 or 7 or 8, whatever, keep your setting so that your ventilator setting so that you'll keep that ETO CO2 down to that level at the very least. And then as soon as you intubate the patient, you want to increase your respiratory rate from the 12 we talked about a little earlier up to 30. You set the tidal volume to 8 cc's per kilo of ideal body weight, and then you increase your flow rate to 60 liters per minute. Now learning focus number 2. Any idea?
This one, I don't think so. I guess maybe when to actually intubate. Oh yeah, anchoring. Yeah, that's what we did.
We both kind of fell into it. Now I can make the excuse that it was the end of my night shift, but that's not an uncommon time for us to fall into the traps that cognitive biases are, right? So there's a lot of information, there's a lot of teaching about that recently, the past multiple years. And in fact, one of the LLSA articles we've had the past few years, you're fresh out of residency. You know,
heard about this in residency, did this in residency.
So there was an LLSA article within the past 10 years or so about cognitive bias. So there's many cognitive biases, and we can't possibly go through all of them. But I wanted to focus a little bit about what I potentially kind of could have fallen into and partially fell into, which is one of these types of cognitive bias, which is anchoring. I love this article. This is an article by 2 physicians, actually one physician, Dr. Decker, and then edited by Dr. Macias. And it's in a blog called newemblog.com, just published last year. And the title is great. When Our Minds Lead Us Astray, Cognitive Bias in the Emergency Department. So anchoring heuristic. What is anchoring? It's basically fixation on your initial impressions, right? So we walked down that road. The guy comes in, he's diabetic, he's having chest pain, he's in a lot of distress, so ACS, PE, dissection, right?
And even seeing that he's diabetic, I'm like, oh, well, that makes him more likely to have ACS. I don't think like, oh, I guess it could be DK. I think this is more likely to be ACS. I'm anchoring on that.
Right. And then what goes wrong? Well, you fail to incorporate additional information into the diagnostic process. Now, we didn't actually fail. It just came later. Later and unexpectedly, I guess, for us, because we were so anchored on one particular set of differentials. And then, so this article is great. It gives all the different types of biases, and then gives an example. So the example was a patient is brought into the ER for a presumed witness seizure, and the physician misses syncope related to the long QT by discounting the EKG findings that do not fit with the first impression of the diagnosis. So anchoring on seizure, as opposed to looking into probably the EKG later on or discounting the prolonged QT. And then the tagline would be tramlining or first impressions or jumping to conclusions, which I don't think we fully fell into this bias, but it certainly led us that way. And so when I thought about the learning focus on this patient, I definitely thought about this as a potential or almost trap that I almost fell into that. Good thing my nose saved me.
Literally.
It really did. And I was so surprised that I didn't even think about AccuCheck. In fact, our staff very typically will get an AccuCheck on a diabetic, whether they have any symptoms related to diabetes or not. So a combination of things that kind of caused the delay of that diagnosis. But learning focus number 2 was about cognitive biases, and I think that we all are subject to it. And in fact, those of us who are in practice a long time may be even more subject to that, right? All right, so let's talk about just the last couple of minutes, the patient hospital course. So he did not get intubated, fortunately, and then in the hospital, he told the hospitals he didn't take his insulin the night before he came in.
Or the night before, or the night before.
Right? Probably. The trope returned to normal the next time they drew it. Cardiologist did see the patient. They did not think the chest pain was cardiac in origin. And then after 2 days, he was discharged home. Yeah.
Still a good outcome.
So good outcome, right, exactly. So did you learn something from this case?
I certainly did. I learned once again that I cannot anchor on a certain diagnosis.
Right. Have you seen a patient that is similar to this very sick decay patient?
Yeah, I remember I had a pediatric patient once, and this was when I was just a brand new resident, and I was actually off shift when my attending said, go look at this patient, and the chief complaint was shortness of breath, or it was a respiratory complaint.
Yes, yep.
And I came walking out, and I was like, his lungs sound pretty clear, like, I don't think this is asthma. And he's like, well, what do you think it is? The kid was poor kid was emaciated. He was very thin. I was at the county hospital, and so, but we ended up checking his sugar, and it was through the roof, and it was DKA again.
Yeah. So those kind of chief complaints can be misleading, right? Chest pain, like mine, but shortness of breath or vomiting, right? Abdominal pain. These are very common presenting symptoms of DKA patients. Well, thanks everybody for watching and your support. I'm so glad, Chris, that you joined me. Thank you for spending the time and chatting with me on this patient. Now we'll see you guys next month. And anytime you see me at a conference, don't hesitate to come up and say hi. I promise you, I don't bite.
She's very nice.
I don't bite. I would like to hear if you've learned anything from my screencast. So anyway, thank you so much. We'll see you next time. Bye-bye.
Bye.